Evening, all of you. My name is Dr. David Sarwer. I'm an associate professor of psychology in the departments of both psychiatry and surgery down at HUP, down in West Philadelphia. And I'm also director of clinical services for our Stunkered Weight Management program and also at our Centers for Weight and Eating Disorders. And I'm very pleased to be here tonight to talk with all of you about some of the new developments that are going on in weight loss treatment. As many of you probably know, this has been a big topic in the media the last couple of weeks. From the cover of Newsweek a week ago that had Michelle Obama talking about the issue of childhood obesity, which we'll probably talk a little bit about tonight, to a major study that just came out yesterday that now suggests that our love and affection for things like bacon and cheesecake are in fact addictions. And while I hadn't planned to specifically talk about that tonight, we will talk a little bit about that if you guys have any questions. But what I hope to do is to give all of you an overview of both the scope of the obesity problem here in the United States, and then what all of you can do individually and in terms of your interactions with your family to push back against this problem, which is truly a problem for almost all Americans, believe it or not. And at the end, I'm also going to give you a little bit of guidance about not only behaviorally based treatments and pharmacotherapy and bariatric surgery, but also talk with you about a couple of different research opportunities that we have down at the University of Pennsylvania that some of you may be interested in participating in. So let's start by defining what we mean when we talk about obesity. Obesity is actually a scientific term with a relatively precise definition, although kind of like we do with things like depression, we sometimes misuse it. But in fact, obesity is best defined by something known as your body mass index, or your BMI, which evaluates your weight relative to your height and is usually converted to the metric system of kilograms over meters squared. And we know that it correlates highly with both percent body fat, morbidity, and mortality. And again, to touch on some recent developments in this area, there's some new research that actually says that our BMI may be even less important than we think, that actually there can be a disconnect between somebody's BMI and the percent of internal fat that they have around their organs, which we know in fact is the most dangerous form of obesity to have. That a lot of people can sometimes look lean but have a lot of fat around their organs and in fact be particularly unhealthy. The typical categories for BMI range from individuals who are underweight with a BMI less than 18.5, which is when we start worrying about conditions like anorexia, to individuals of a normal or average body weight with a BMI between 18.5 and 24. And then as you can see, once your BMI rises above 25 and then grows into the 30s and beyond, we have individuals who are classified as overweight and then those who are classified as being clinically obese. And I'm sure some of you are a little bit curious of what your BMI is. And so if you've never calculated it, this is an opportunity for you to calculate it tonight. Along on the left-hand column, you can see an individual's height. So you can find your height on the left-hand column and then find your weight across the top. And then the interaction of those two numbers will give you your body mass index. Individuals in the white category in the right grouping down here are considered to be underweight. Green is considered to be the average body weight. And as you move from yellow into orange and then red, we're now talking about individuals who are overweight and then clinically obese. Many of you, in fact, may remember years ago, and this probably goes back about 10 years ago now, where many millions of Americans woke up and were classified as being overweight, even though on the Tuesday night before they all went to sleep being of average weight. That these criteria actually downshifted about 10 years ago. And one of the things I'm actually somewhat proud of when we talk about body mass index is when I started working in this area about 15 years ago, and we would give talks like, my colleagues and I would give talks like this to physicians, we would say, you need to start calculating your patient's BMI not all that differently than you get their blood pressure and their pulse rate at every visit. And I'm actually somewhat proud to say that physicians now, by and large, calculate this. And in our electronic medical record system here at Penn, this is now one of the entries that goes in every time you see a physician within the Penn system. Another way to define obesity is to say, well, what does it really look like? And you could say here, for a woman who's 5 feet 4 inches tall, she would on average, a normal or average weight woman would have a weight of about 130 pounds, and she'd have a BMI of 22. If she was 152, her BMI would be 26, meaning she'd be classified as overweight. If she gets to 175 at 5'4", she now has a BMI of 30, so she's crossed the threshold into being clinically obese. And then we could see different degrees of severity of obesity, including an individual who's extremely obese, who's 100 pounds over their recommended body weight with a BMI of 40. Now, I'm going to give you a snapshot of what's happened to the obesity problem here in the United States in the next couple of slides. The CDC actually has these publicly available. So you can go to the CDC's website and actually see how this graph changes year to year. I'm actually going to show you only 5-year increments. But back in 1985, all the states that are black mean that the states didn't even bother to calculate what percentage of their citizens were clinically obese. But you could see that, for example, it wasn't calculated here in Pennsylvania, but if you look at Ohio and Indiana, 10 to 14% of residents of those states were clinically obese, and that some of the western states it was less than 10%. So this is 1985. Fast forward to 1995, when I got involved working in this field, and you could see that all the states are beginning to record this data. But look what's happened to some of those states in the Northeast. They've jumped up. They've gone from that 10% now up to 15 to 19%, which in 1985 wasn't even a category. In 1985, we didn't have a single state whose population was greater than 15% of their population was clinically obese, and now half the country is in 1995. Look at it today, or at least in 2006. The only states that remain blue are up in the Northeast and Colorado. But look at some of the other states. So you look at Mississippi and West Virginia, more than 30% of the residents in those states alone are clinically obese. Most of the Northeast between 25 and 29, or most of the Midwest, 25 to 29% of the residents of all of those states, clinically obese, meaning they have a body mass index over 30. Kind of staggering when you break it down. As I said, you can actually go to the CDC website, look at all these slides, and actually flip through them like those flip charts that kids use, to show how a picture moves. And it's really staggering to see year by year how the disease of obesity has really progressed. This is another way that we like to look at the data. So if we look just from what's called the Enns-Haynes survey, which is a nationwide survey of nurses that's been conducted by Harvard over the last 50 years now, I'm sorry. You could see that from 1960 to 1980, the rate of overweight and obesity in the United States was stable. That about 12% of the American population was obese, and that another 25% was clinically overweight, so that a BMI between 25 and 30. And then we look at 1988 to about today, we see a dramatic uptick, which leads many of us to think, what happened? Why have we suddenly seen this change? Why has something that can be explained, as we'll talk about in a moment, both physiologically as well as environmentally, why have we suddenly seen this change? And there are all sorts of hypotheses, some of which are very intuitive, some of which are quite counterintuitive, which suggest why this has occurred. We're also seeing that the heaviest among us are growing at the fastest rate. That if you look at the rate of individuals with BMIs greater than 30, so garden variety of obesity, they're along the bottom there, and you see that from 1987 to 2005, the percentage of individuals in America increased by almost 200%. But look at those with a BMI of 50 or greater. That percentage went up almost 1,000%. Staggering, staggering numbers, let alone when we start thinking about the healthcare implications of all of this. And we're not going to get into politics, we're not going to talk healthcare reform, we're not going to talk any of that stuff tonight. But for those of us who work with patients on a regular basis, and we deal with the comorbidities associated with obesity, these numbers keep us up at night with fear, because we are incredibly poorly prepared to deal with this problem, not only now, but 10 and 20 years from now. It's not just the adults, it's our children. So look at what we're seeing in terms of the similar uptick in overweight and obese adolescents in the United States. And that's why so many of us are so thrilled that the current administration, say what you will about them and their politics and their views, is taking this problem head on. Because it's a very significant problem. And when the Surgeon General comes out and says, I'm concerned that our kids will not have an increased life expectancy for the first time in recorded history, she's not just blowing smoke, because most of the evidence suggests that's going to happen. And it's all going to be because of this. While we often think about overweight and obesity as an aesthetic or a cosmetic issue, and without question, almost everybody we see in our clinics, everybody we see in our research programs wants to lose weight because they want to look a little bit better. We also know that it's associated with a whole host of significant medical problems. You know, some of them are very obvious when we think about things like type 2 diabetes and heart disease and hypertension. But we also know that it's associated with a whole bunch of gynecological abnormalities. So in the last few years, I've been working more closely with some of our reproductive endocrinologists, trying to figure out the best ways to treat younger women who want to have babies, but can't because they're too heavy. And their obesity is throwing off their reproductive hormones, which is interfering with their ability to conceive. We know that it's associated with different forms of cancers, typically of the reproductive organs, and in large part because we used to think that fat was inert. We used to think it didn't do anything. Well, now we know it's actually living cells, and it messes with our hormones. So testosterone, estrogen, all of the other reproductive hormones can go a little bit screwy. Remember, I'm a psychologist, so I can't be more technical than that, if you're obese. We also know that a variety of our major healthcare problems can be directly attributable to being obese. So just start right at the top. Type 2 diabetes. 90% of all cases are related to being overweight or obese. Hypertension, 2/3 of cases related to being overweight or obese. Again, for those of you with young kids at home, we used to call type 2 diabetes adult onset diabetes. We can't anymore because kids get it. You talk to pediatricians who've been in practice for a long time and they say, I never had kids with diabetes 20 years ago, I got them now, and I've never seen kids this big before. And they don't know what to do with them. And the schools don't know what to do with them. We also know that being overweight or obese increases your risk of a premature death. So this is a little bit of a complicated slide, but if you look at women and men who have never smoked, is that a little fuzzy for you guys, by the way? Okay, I just, from my angle, it looks a little bit fuzzy. I'm sorry we're not a little sharper on the picture, but if you follow this line, we've got BMIs along the bottom. Here's my arrow. So if your BMI is below 25, which again is the cutoff between average weight or overweight, your risk of a premature death is no greater than it would be otherwise. But as your BMI increases, your risk of a premature death doubles, then triples, and keeps going up. These are non-smokers. You add smoking to the mix, the curve is even sharper still. So pretty frightening stuff. And my purpose tonight is not to frighten you with all of this, but to give you kind of a scope of the problem. My colleagues and I deal with these numbers and these statistics day in and day out when we're dealing, writing our academic papers and giving talks and so on. And it's sometimes, even though you may not want to hear all of this, it's sometimes useful to be in front of an audience who's maybe hearing some of this for the first time, because the looks on your faces say an awful lot back to us about, wow, this is pretty uncomfortable stuff. Why do we have this problem? Well, it's probably a multifactorial disease with genetic and environmental components, biochemical issues, cultural and psychosocial issues. And my colleagues and I, for the most part, fall in that environmental camp of all places. And I probably tip my hand a little bit when I'm talking about things like microwaves and Sesame Street. But you should know that there are colleagues of mine down at Penn who focus more on genetic issues or focus more on hormones and physiology, who would essentially be here tonight and give you a completely different talk than the one I'm giving you, who would say this is all about hormones and neurotransmitters and so on and so forth, and that's why we got to come up with better drugs and genetic markers and so on and so forth. And while some of that may be true, we point our finger at the environment in large part because guess what? That's something you can do something about. Because it gives you a little bit of hope in terms of what can you do for yourself or your family in order to control your weight going forward. One of the big things we point our finger at is something called the toxic environment. This is a term that was coined by a former psychologist at Penn named Kelly Brownell, who's now up at Yale University. And Kelly was voted, I believe, 2 or 3 years ago, was in the Time magazine's 100 most influential people in the country. And he's been in those movies like Fast Food Nation and Food Fight, and he's the guy who often says that we should be taxing fast food and all that kind of stuff. And so people like to make fun of Kelly for that and say that he himself is out to lunch and so on. But he's the one who coined this idea that we live in a toxic food environment. And we can think of countless examples of this. One of the ones I like to give to my students is when I was an undergrad, you couldn't bring food into a library. Now we have coffee shops in libraries on Penn's campus. So, you couldn't bring food in because they didn't want you getting crumbs or coffee on any of the, super old volumes. Now they have coffee shops so you can take your food and drink through the stacks with you. It's all about making money for the library. That's all it is. There are Home Depots out there that have little food stations in them or in the front of the stores, which doesn't make any sense until you think about that it might be handy for your contractor to get food if they're redoing your kitchen one day. But think of the number of times that all of us, when we're there on a Saturday, I didn't think I was really hungry, but let me grab myself a hot dog anyway. And then we don't really think that that's food that counts in some ways. An interesting little twist, and you may hear a little bit more about this, and some of you actually may have read about this morning. So Kelly Brownell is up at Yale University. He's probably the strongest proponent of this notion of the toxic food environment. And he goes after the big food companies, and he says unabashedly, this is Coke's problem, this is Pepsi's problem, this is McDonald's problem, all of this kind of stuff. Just announced yesterday, Yale has accepted a $250,000 gift from PepsiCo to support the training of MD, PhD students who are going to research the nutrition obesity problem. Now, what's kind of curious about the whole thing is that Kelly's name isn't mentioned anywhere in the article, and he isn't even quoted for an opinion. I can't wait until I find out what he thinks of all of this. Because there are alums at Yale, and apparently one of their board of trustees members also on the board of PepsiCo. But there are alums at Yale who are livid, and their physician faculty is livid, saying, how can you ask us to help our patients, and then you go and essentially sign this kind of contract? And it was very discouraging to read it this morning. Unfortunately, I don't know the whole story to it, but really shows and illustrates the power of the food industry and the food lobby. It's not just what we eat and the availability, it's also the portion sizes. And one of the nice things about this slide is it allows me to tell a little childhood story. As I mentioned a few moments ago, I grew up outside of Chicago. And I actually grew up about 5 minutes from a place called Hamburger U. And Hamburger U is where if you buy a McDonald's franchise, you go and take a crash course in learning how to run that franchise. And right in the front of Hamburger U is a working McDonald's where you get to learn how to cook the fries and do the budgets and all that kind of stuff. So when I was a young guy in the 70s, one of the very popular things to do for a birthday party was to go to McDonald's at 10 o'clock before it opened and watch them set everything up and take the food off the trucks and turn on the fryers and make the first round of burgers and watch them put the shake stuff together and all that stuff. And then your lunch was a small hamburger, the little bag of fries, And they didn't have the ice cream sundaes yet, so I think like you got an apple pie. No toy. And oh, by the way, McDonald's is the largest toy distributor in the United States. So no toy, no supersize, no nothing. I don't even think you can get the bag of fries anymore. I think you're obligated to get one of the, it may not be the extra large, but something like the red box on the right. But think about how McDonald's has changed in those 40 years. That it's now open 24 hours a day, that you can get breakfast, then lunch, then dinner. Think about, back then it was, an exotic meal there was filet of fish. Not, the burrito wrap, whatever that it is today. They have figured out a way how to cater to our wants and desires and make an awful lot of money while doing it, and we kind of have gone along with the flow. Not surprisingly, the evidence tells us that over those last 30 and 40 years, our caloric intake has increased. Remember that the USDA tells us that we should eat about 2,000 calories a day. Unfortunately, my water does not have a label on it. So back in the 1970s, Americans were eating less than 2,000 calories a day. So they weren't gaining weight, they weren't losing weight, but slowly over time, look at how our caloric intake has increased. And while that 250 calorie increase up to 2205 might not seem like a lot, 100 calories a day, every day of a calendar year, more than what your body needs, will put on 10 to 15 pounds of weight. So that's a handful of cookies. That's a handful of potato chips. That's a can of soda. Not the 20-ounce bottles, mind you, the cans. And that's why, in some ways, for many people, their weight has just slowly crept up on them. It's been a process of not sitting in the back of a Wawa eating a half gallon of ice cream 2 nights a week. It's been 100 or 200 extra calories a day, every day, for 5, 10, 15, 20 years, and suddenly you wake up and your doctor says, by the way, you're clinically obese and you've got diabetes and hypertension. This is the United Terminal at O'Hare, the one where if you go between the terminals, you got to go under the taxiways and you go through the tunnel with the lights. This is one of the stairwells. So you've got 2 sets of escalators that are full and one lonely soul up at the top of the stairs. This is a great opportunity for him to get some for somebody to get lifestyle activity, whether they have luggage or not, and to burn some more calories. But our default is now, where's the escalator, where's the elevator? I'll drive around to park as close as possible. And all of that adds up, and we therefore are less active than we used to be. So we're going to focus on these 3 main categories of weight loss treatment. So we're going to start by talking about diet and exercise and behavioral therapy, which is otherwise known as lifestyle modification. We're going to talk a little bit about pharmacotherapy, and the news there is not very good. And then we're going to spend some time talking about bariatric surgery. So in terms of lifestyle modification, it comes in all different kinds of forms, from self-help books to even things like Atkins and South Beach, to programs like Weight Watchers and so on, and then clinical trials like we do down at the University of Pennsylvania and that you'll find, or if you came to our Stunker Weight Management program here or downtown as well. And really they usually incorporate these 3 facets. So getting individuals to eat a low-calorie diet, getting them to increase their physical activity, and then also a little bit of focus on behavioral therapy, in which we borrow from cognitive behavioral psychotherapeutic principles to get people to identify their maladaptive behaviors and change them out for more positive ones. So let's say, for example, that when you went back to work, you fell in the habit, and I'm not picking on you, but you just gave me a really good example, that you fell in the habit of every Friday you would go to a coffee shop with a good friend who also taught in the school, and you guys would get a big tall coffee and a piece of cake that you would share. And as a result, on those Fridays, you would eat 500 more calories than you would. And you got in that habit and you did it for a decade. That behavior in and of itself, 20 pounds of weight. You know, the difference between a regular soda and a diet soda. Think about if you weren't here tonight, what would you be doing? You know, would you be, being here at dinner time forced you to change your schedule a little bit? Could actually doing this be a healthier behavior than if you went home right from work and overate at dinner? One of the big things we see with people is how they get out of their habits when they have to deal with a major life stressor. So a sick relative, a child who's having some issues, a change in a job. All of those things can take what are sometimes very good habits for people and really throw them out of sync. You know, you've got a sick relative who's in the hospital or in a nursing home, and you go to visit twice a week, and as a result, instead of eating at home, you're swinging by a fast food restaurant, and you get in the habit of going to McDonald's and Burger King 2 nights a week. Over time, that adds up. In terms of one of the things we ask our patients to do is self-monitor their intake, which means writing things down or using an online mechanism to record their intake. And yes, I will acknowledge it's painful, it feels like homework, and it's also the best tool that we have for you to identify the behaviors that you're engaging in. So not only the types of food, but the portion sizes, what are the calories that you're consuming, and the times, places, and activities. So when you watch Dancing with the Stars or American Idol, do you get in the habit of eating a really large bowl of popcorn with an awful lot of butter? And over time, does that add up and have a negative impact? It can help you illustrate the difference between eating a muffin for breakfast, which over there on the left-hand side would be your USDA recommended muffin size, or eating a muffin for breakfast. And think about it, our American approach to this, if we go somewhere and ask for a muffin and we're served the muffin on your left, we feel a little cheated. We're used to the muffins on the right when we go to coffee shops. And the way the restaurant business works is they like to get us to come back in with really large portion sizes that taste really good. And the first rule of cooking, which somebody told me because I can't cook, is if you want to make something taste good, add more fat, which means more butter. Think about the number of restaurants, some of which are not very far from here, that pride themselves on their enormous portion sizes. Places like the Cheesecake Factory and Maggiano's, you know, those family portion sizes. Well, even if you're actively trying to not eat the whole portion size, you're probably eating more than the recommended portion size. Steakhouses that brag about 24 ounces, 48-ounce steaks, and so on. But the recommended serving size of a steak is about 4 to 6 ounces. So if we're just going along with the flow, we can end up overeating without not a great deal of awareness. Another little history tour. When Coca-Cola was first introduced over 100 years ago, the first standard serving size was that 8-ounce bottle on the left, which was replaced by the 12-ounce can in the 1950s, and then replaced by the 20-ounce bottle about 15 years ago. Go to any Wawa today, it's easier to find the 20-ounce bottle than the 12-ounce can. So let's say that you're a lifelong Coca-Cola or Pepsi drinker, and you drink, as the evidence tells us we do, to the size of the container. Because we're creatures of habit that way. We typically finish whatever's in front of us, regardless of the size. 20 years ago, you were drinking a 12-ounce can every day. Now you're drinking a 20-ounce soda, and you probably didn't give much thought to the fact that you've almost doubled the portion size and therefore doubled the calories. Another thing that recording your intake will allow you to do is track your behaviors in a behavior chain. So you can begin to see what are some of the kind of unconscious, unknowing behaviors related to your eating. In terms of the standard dietary recommendations that we use in treatment, as do most other programs, getting people to reduce their intake by 500 to 1,000 calories a day with the objective of losing about 1 to 2 pounds of weight a week, which is a safe rate of weight loss, which is unlikely to cause significant health problems. And we, like most programs, typically recommend a balanced deficit diet where we don't do things like eliminate carbohydrates or anything dramatic like you would see with an Atkins or a South Beach approach, but it's really more just decreasing your calories across the board. We don't believe and endorse the notion of forbidden foods because I think unless you're prepared to give up a food for the rest of your life, there's no point in saying, I'm not going to eat this. So there's no point in telling a native Philadelphian, no cheesesteaks, no water ices, no pretzels, unless you're prepared never to do it again. Because the minute you violate your own rule, you're going to feel horrible and you're going to say, you know what, I already burst through the dam, let me eat more and more and more. So it'd be more moderation. So if we see a patient who's coming in and having 2 cheesesteaks a week, we'll say, can you go down to 1? Can you go down to 1 every 2 weeks, but make sure that you always go to your favorite place and not, just have a cheesesteak for the sake of having it. If you're going to have a cheesesteak, go have a cheesesteak. Don't buy an inferior product. As you know, from time to time, there's all this controversy about which diet is best. If you look here at the slide, which was a study published in 2007, you could see that over the course of 1 year, the difference between doing the Zone or the Ornish diet or the Atkins diet or the Learn program, which is a behaviorally based program, is about 1 pound. So even though you can see all this hype and headline, proven weight loss effort, that's just to get you to buy the books. But if you also notice, now that's in kilograms, so for pounds you can essentially double it. People who are on the Atkins diet for a year, and they do the Atkins diet, not just do it for a couple days and then quit like most people, they lose about 8 pounds. Not all that impressive. But again, we sometimes get fooled by the marketing mechanisms that lead us to think that these things are far more successful than they really are. These are the USDA physical activity recommendations, and these are pretty ambitious. So if you're going to try to prevent an unhealthy weight gain, the recommendation is that you get up to 60 minutes of moderate to intense activity on most days of the week. But look at the bottom. To sustain a weight loss, so to lose weight and keep it off, the recommendation 60 to 90 minutes per day. Who has 60 to 90 minutes every day to be that physically active? Not too many people I know. Not particularly if they're trying to balance career and family demands and a little bit of sanity. This is also why physical activity is not the secret to losing weight. It is far more efficient to reduce your caloric intake than try to burn the calories off once they're in your body. Very concrete example. You get up tomorrow morning, you go to the gym, or you go down to your basement, you get on a treadmill. Let's say you walk for 30 minutes, you burn 250 calories. If when you go upstairs, you open up the refrigerator, grab a piece of fudge as you're getting your bottle of water, plop that piece of fudge in your mouth, you were better off sleeping for an extra half an hour. Because you've now just undone your 30-minute workout in about the 3 seconds it takes you to eat the piece of fudge. There are a number of different slides that I could show you in terms of the effectiveness of behavioral weight control, but I'm going to focus on something called the Diabetes Prevention Program. This is one of the largest studies to date, which was over 5,000 Americans throughout the country who were all pre-diabetic at the start of the study. And the purpose of the study was to say, if we help people lose a little bit of weight, do we reduce the number that develop full-blown diabetes? So at the onset of the study, people were either randomly assigned to a placebo drug, metformin, or lifestyle modification the way I just described it. And as you could see, at the end of the first half year, those in the lifestyle modification group lost about 15 pounds, whereas the placebo group didn't lose any weight and metformin lost about 4 or 5 pounds. And the lifestyle group did a reasonably good job of keeping that weight off over the next 4 years. But here's the most important finding of all. This is the rate of new cases of diabetes developed over the course of the study. So remember, at the beginning, everyone was pre-diabetic. Those in the placebo, almost 40% were diabetic at the end of the 4 years of the study. But in the lifestyle group, only about 20%. So 58% reduction between the placebo group and the lifestyle group. So while patients didn't lose a ton of weight, most of them did not become diabetic over the 4 years of the study, suggesting that these modest weight losses can really have a profound effect on people's health. Let's move on and talk a little bit about pharmacotherapy, which is typically recommended for individuals with a BMI of 30 or greater, or down to 27 if they have another comorbid condition like diabetes or hypertension. So the base of our treatment pyramid is lifestyle modification, and that's really the first line of defense for weight loss. Then as things get more severe, we start talking about pharmacotherapy. Currently, we have 3 medications approved for usage in the United States, but many of us think that's actually going to change either up or down, and probably down and then up before the calendar year is over. One medication is called sibutramine, otherwise known as Meridia, and it induces feelings of satiety or fullness very much in much the same way that the SSRIs are used for depression and anxiety. It's actually a medication that was originally targeted to be an antidepressant. Turns out people's moods didn't improve, but they lost weight. You take it once a day, 10 to 15 milligrams a day, and the average weight loss in 1 year is about 10 pounds. But there's concern that the FDA is likely going to pull this sucker off the market before the year is over because it's already off the market in Europe. What happened was, in one of the large post-marketing studies that drug companies are required to do, the one that was being done in Europe is actually finding a higher than expected death rate of people on the medication with a pre-existing cardiac condition. So the FDA is still reviewing the data, but all of the indications seem to suggest that it's likely going to be pulled from the market. But even while it's still on the market, you have to monitor your blood pressure closely, that about 5% of people who go on the medication, actually their blood pressure spikes, and they have to be weaned back off it very carefully. The other medication that's available in prescription form is Orlistat, otherwise known as Xenical, which is also now available in the over-the-counter version called Ally. That medication works very differently in that it blocks the absorption of fat in the small intestine. You have to take it before every meal, and the average weight loss is slightly less than what we see with sibutramine. I think that this is a very challenging medication for people to take who aren't at a desk all day, because it doesn't block all the fat, and if you eat a high-fat meal, you run the risk of developing some pretty nasty, unpleasant, socially awkward GI symptoms. And let's leave it at that. And so patients oftentimes will try it, and then as soon as they have one of those events, they stop taking the medication as opposed to changing their diet. Because it's really, it's aversive conditioning at its most beautiful. You go to the Cheesecake Factory, you eat a big piece of cheesecake while you're using Ally, you might soil yourself. That's your body's way of saying, don't go to the Cheesecake Factory, but instead a lot of people discontinue the medication. The other medication that's available is phentermine, which used to be part of the fen-phen combination. This was the part that was not causing cardiac problems, but is only really approved for short-term usage up to about 3 to 6 months. There are a few physicians out there who are, 1 to 2 months. There are a few physicians out there who still prescribe it, but not many, because it's not approved for long-term usage the way the other two are. Now, rumor has it that there are anywhere between 2 to 4 other medications that might go in front of the FDA before the calendar year is over, but the last medication that went in front of the FDA got voted down 16-0. And if the FDA is going to pull sibutramine, most people think what's going to happen is going to be a very steep climb for any company to be able to demonstrate safety and efficacy of a new medication. And so while it's possible that we might see a new medication before the year is out, the reality is A, we might not, and B, they're not any more impressive than behavioral therapy. And while the decision hasn't been made yet in terms of healthcare reform, what's going to happen, most insurance plans in Pennsylvania do not cover these medications, and they cost you about $100 a month out of pocket. So the average length of prescription wait with these medications is about 60 days. Meaning that people get it, they try it for a month, they try it for another month, they don't lose a lot of weight, and they say, I just wasted $200, I'm going to try something else. Here, what are the limitations? I just went through them here. The side effect issue that you don't really lose that much more weight, if more weight at all, and there's actually no long-term studies proving safety and efficacy. Plus, when you stop using the medication, most people regain their weight. So but yet, when the next one comes out, I bet you it makes front page news. One of the things that we've been doing at Penn with some of our more recent research is actually looking at, can we combine treatments? Now, this may seem surprising to you, but really there haven't been a lot of studies that have been done that have combined a medication with a really intensive behavioral program. And the reason for that is because the drug companies are concerned when they go to test the efficacy of their medications that if the behavioral treatment in the placebo condition is too good, they won't show any added benefit of the medication. So we've actually started to do some studies at Penn where we've said, well, if we combine medications and pharmacotherapy, do we get additive effects? And in fact, in one of our studies, and I apologize that some of this got erased, people who use sibutramine in combination with a very intensive group behavioral modification program lost about 20 pounds, which was significantly greater than those on medication alone or in behavioral treatment alone. So it really seems like if you really want to use a weight loss medication, you should use it in conjunction with a really good behavioral program. Not just go to your physician and get the medication and think the medication's the magic bullet which will take care of everything. Let's move on to, well, let's talk briefly about our stunted weight management program. So for the last 50 years, I haven't been at Penn for 50 years, only 15, but our program has focused a great deal of our attention and time on research. And so we do clinical trials on a whole bunch of different weight loss interventions, from behaviorally based to pharmacotherapy to, in the last couple of years, we've done drug studies. We've done a study with almonds. We've done a study with Wrigley's chewing gum, all sorts of different ways to see, do these products help people lose weight? And a few years ago, we actually developed a clinical arm to our program, which is named the Stunted Weight Management Program, a tribute to our director emeritus, Mickey Stunkard, who is one of the deans of obesity and eating disorders research, who is 87 years old, still comes to the office as much as he can, even though he has to take a cab back and forth from the main line every day. Was in his office today. Very proud to say it's right next to mine. But as a very nice tribute to his lifelong work in this area, we named the program after Mickey. And our philosophy is really simple, that our overweight and obese patients should be treated both compassionately and professionally. That we know that not only in society in general, but also within healthcare systems, let alone other areas of society, people who struggle with their weight are treated differently, meaning often poorly. So we now have a multidisciplinary treatment program which is dedicated to providing the highest level of care to all of our patients, based in large part on some of our research excellence over the years. Our core program is something called Health First. This is a 13-week program that relies very heavily on meal replacement products. So we have a partnership with a company called HMR, which stands for Health Management Resources, which is in the same vein as the OptiFast, Medifast, Nutrisystems of the world. They have a very structured 13-week program which is led by our dietitians and also supervised by our nurses and nurse practitioners, designed to help people lose a significant amount of weight in that 13 weeks in a combination of this reduced calorie diet and weekly lifestyle modification classes. We then ask patients or invite patients to then think about enrolling in one of our Encore programs, which involves ongoing support and long-term maintenance, where patients come back usually every other week for support group meetings. A lot of patients, even at the end of the 13 weeks, say they want to continue to lose more weight, and so we encourage them to do so. Let's talk about bariatric surgery. This is an issue that's near and dear to my heart, in part because it's a large focus of both my research as well as the clinical work that I do downtown. I'm very fortunate right now to be involved in a number of different projects funded by the National Institutes of Health, which are looking at the safety and efficacy of bariatric surgery. There are two main procedures most widely practiced here in the United States. On the left is what's known as the adjustable gastric band. What the band actually involves is putting a silicone ring, kind of like this, around the upper part of your stomach. And you can actually, I'm going to use the arrow. You can actually see it here, although it's not that clear, around the upper part of the stomach, which is then connected to this port, this white tube here, and a port that sits then right underneath your rib cage, so about right here. A physician or nurse practitioner then can take a very long needle filled with saline, shoot it into that port, which then goes up into the band, and the band clamps down, restricting the amount of food that you can eat. The other common procedure in the United States is the gastric bypass surgery. This is the more invasive procedure that also involves creating a pouch, but not with a band, but rather with a staple line. So it's a little hard to see on that slide, but right here, the surgeon comes in and creates a staple line, essentially dividing your stomach. He or she then disconnects your small intestine, reconnects it to the pouch, so this lower part of your stomach and the upper part of your small intestine are now bypassed, hence the name. So the functional size of your stomach in both of these cases gets down to about the size of my thumb. So instead of being able to eat 2,000 plus calories a day, patients by and large can only eat 1,000 to 1,200 calories per day, and which produces a very large weight loss. The average weight loss with a banding procedure is about 25% of your current weight. With the bypass procedure, it is about 1/3 of your current weight. It takes about 12 to 18 months to lose that weight, but then there's usually some weight regain that occurs over the next 10 to 15 years. The trade-off, while both of these procedures can be done laparoscopically, the trade-off, this procedure has a death rate of 0.5%, which means 1 out of every 200 patients dies. The band has a much lower death rate, and the deaths are actually very rare, usually related to severe infections with the band. The major complication rate with the bypass is about 15%, and when I mean major complication, it would be a complication that would bring you back into the hospital. So about 1 in every 6 or 7 patients has to be readmitted for one reason or another. With the band, it's about 5%. So you're getting a slightly larger weight loss here, but you're also taking on more medical risks with this procedure. Whereas with the band, you're getting a smaller weight loss and less risk. Now, there's some other advantages to both procedures we'll talk about in a moment. Now, in terms of evaluating somebody for surgery, there are some basic factors that we look at. One of which is biological right off the bat. So you need to have a body mass index greater than 40 or greater than 35 in the presence of a major comorbidity. And the major comorbidities are typically diabetes, hypertension, heart disease, sleep apnea, dyslipidemia, and osteoarthritis. So any of those typically qualify.
What was that factor the last time you said?
I can't remember.
Dyslipidemia.
Dyslipidemia.
What is that?
High cholesterol. I'm glad you remembered at least part of it, because I can't remember what I said 2 seconds ago. It's been a long day. One thing just of note, there is a movement afoot among the bariatric surgery community to lower that BMI criteria down from 35 to 30, particularly when we talk about cases of type 2 diabetes. And we actually have a research study down at Penn that we're doing now, which I also brought flyers for, and I'll explain to you in a few moments, where we're going to actually start to look at the safety and the efficacy of bariatric surgery for individuals with type 2 diabetes, because that's where we seem to see the most impressive health outcomes. So those are the biological factors. Environmentally, what we typically look for is patients' eating habits and have they dieted previously. We then also look at social, psychological factors. But in terms of these environmental factors, we typically want people who have tried to lose weight through other means. And so they can use that fund of knowledge to help them change their diet with surgery. But we also don't want to, if people have a fighting chance to lose weight through another way, we want them to do that before they take on the risks of surgery. We also look very closely at their current eating habits, and we'll often ask patients to go through some nutritional counseling before surgery to really get them from going to McDonald's 5 times a week to going to McDonald's rarely, if ever. We also try to get patients to increase their level of physical activity and then also make sure that they understand what the behavioral program involves. When we relaunched our bariatric program in 1998, and Penn's program hasn't done a lot of advertising over the years, some of our patients knew as much about bariatric surgery as we did because they had gone to the NIH websites and they had read the papers and they knew all about it. And in the 12 years since that time, as bariatric surgery has become more and more popular, there's been more media coverage, we've seen more and more people who, while they've learned about bariatric surgery, they've learned about it from the mass media. And the mass media's depictions of bariatric surgery can be very different than what really goes on. Because those stories can make for really compelling television, but they don't show a lot of the nitty-gritty stuff that people need to do to be successful. And this is an awful lot of hard work. So we want to make sure that people really understand that their days of going to McDonald's and their days of drinking regular soda and their days of eating chocolate are more or less over. Prior to surgery, patients on average are consuming about 2,400 calories a day or more, and their dietary quality ranges from people whose diets are actually quite good, but they've been blessed with bad genetics or they've learned their lessons through these other programs, to some really poor diets where people are going to McDonald's 2-3 times a day. They're eating all their meals at fast food restaurants, and it's not particularly surprising that they're over 100 pounds over the recommended body weight.
I haven't seen anything about a qualification for age.
That's because there really aren't any.
Oh, okay.
On the low end of the spectrum, the NIH recommends surgery for individuals 18 or older. You can do bariatric surgery on an adolescent under the age of 18. The bypass is considered experimental. Some insurance companies will pay for it, others will not. The banding procedures are also considered experimental, and insurance companies largely will not approve them, although one of the banding companies, a company called Allergan, which I'm also a consultant with, is actually trying to get the FDA to approve the use of the banding procedure down to individuals 14 years of age. On the older end of the spectrum, the thought used to be 65. And then when Medicare, Medicaid made their statements about bariatric surgery years ago and said there's no reason to have an upper age limit, the reality is that they cover it for everybody. Our average patient is 44, and then as you move to the 30s and 50s, our numbers go a little lower, and as you move to the 20s and 60s, they go lower still. And then we have a handful of teens, and we have a handful of 70-somethings. Not a lot, but I think our oldest patient's 73, and we've had a couple of others that have been 70 or more. In terms of social and psychological factors, we want to make sure that people aren't struggling with depression or binge eating disorder. A couple times a year, we'll see somebody who's actively bulimic or individuals with substance abuse or other significant psychiatric illness. But usually in those cases, we actually just try to make sure that their disorders are well controlled and not use psychopathology as a way to screen people out from surgery. We also want to make sure that patients aren't struggling with major life stressors, that they understand the required behavioral changes, and that they're ready to change those behaviors. So I just saw a teacher earlier today who is a very good candidate for surgery who says, I want to do this in early July so I can spend July and August recovering and I can go back to school in September. Sounds good to me. If she would have said, I want to cram this in before the end of the semester and while I'm helping my students prepare their yearbooks, I would have said, we're rushing this. So you really need to be in a position where bariatric surgery and following and learning this postoperative diet becomes a major focus of your life. I gave you an estimate of the average percent weight losses before. This is actually the longest and largest study done to date on bariatric surgery. This green line at the bottom, and again I apologize for the fuzziness, will tell you that with the bypass procedure, the average weight loss, like I said, is about a third of your body weight within the first couple of years, and then patients begin to regain some of their weight. The orange line up here is the equivalent of today's banding procedure. So again, you lose about 25% of your weight and then slowly begin to regain your weight over time. In terms of comorbidity resolution, on average, with combining both bypass and banding patients, 78 or 76% of cases of type 2 diabetes are resolved. 86% resolved or improved. And the improvements in hyperlipidemia or dyslipidemia, hypertension, and sleep apnea. So the impact on the comorbidities is dramatic. One thing I just want to invite you all to think about, and this is an area where my colleagues and I are doing a lot of research. While without question bariatric surgery is the most powerful tool we have in the weight loss toolbox, approximately 10 to 20% of patients are either failing to lose a significant amount of their weight or they're regaining their weight prematurely. And that could be for a variety of different factors, such as out-eating the band, disordered eating, pre-existing psychosocial characteristics. But one of the things that we're really focusing on, which is poor adherence to the post-operative diet, which is patients really aren't following what our dietitians are telling them to do. And this is a study that we published in 2008, where we looked at patients who reported high levels of adherence to the diet being taught by the dietitians and low levels. And what you could see is as early as 40 weeks after surgery, those who were following the diet more closely were losing significantly more weight. And look at how those in the low dietary adherence group right here have actually started to regain their weight between weeks 66 and 92. Which really makes you begin to wonder, as we start going into years 3 and 4, do they continue to rebound this way? Which has led us to say there needs to be a number of different things that we do to really help patients follow this rigorous postoperative diet. This just looks at caloric intake, and I know it's a little small on the top, so I'm just going to cruise through it also for the sake of time. Patients on average before surgery are eating about 2,400 calories a day. Goes down to less than 1,200. But by postoperative week 92, they're already up 150 calories more a day than they were before, which means they're beginning to creep. And some of our patients at that point were actually back above 2,000 calories a day. So let me go ahead and, just for the sake of time, so we can open things up to Q&A, talk to you very briefly about this research study. So we were very fortunate to get a grant from the National Institutes of Health to look at this issue of bariatric surgery and type 2 diabetes. And so you might have seen some of our advertisement for us or the story on CBS 3 News a few weeks ago. What we're doing is a randomized controlled trial where we're going to be comparing the 2 different bariatric procedures to an intensive lifestyle modification program for individuals with a BMI less than 40. So we're going to take 32 individuals and randomly assign them to either the band, the bypass, or a medical weight management program, and that they're going to get free weekly and biweekly treatment in all of these conditions. So they're going to get free treatment, and all of your assessments and medical coverage will be covered as well. This is a 2-year study, and that all of our patients will be asked to do screening visits both before the study. There's a screening visit, there's assessments before surgery, after a 10% weight loss, and then 6 and 12 months after the surgery or the start of behavioral treatment. And in terms of the entry criteria, I'll just cruise through this. This just is the reimbursement on the study, that all study-related items will be provided at no charge, and that patients are actually also going to be reimbursed and receive a financial honorarium for participating. And the inclusion criteria is we're looking for individuals with a BMI between 18 and 60, or I'm sorry, age of 18 to 65, a BMI of 30 to 40 with type 2 diabetes, defined as either by a pre-existing diagnosis, use of a medication, or a fasting plasma glucose greater than 126. They have to have insurance coverage for surgery, but that may actually change shortly. And then those are the exclusion criteria. But I brought a variety of different recruitment materials with me for any of you who might be interested. So there are brochures over there as well as that hot pink flyer. So since we're running a little long on time, that's my correspondence, and unfortunately my email address is whited out there, but it's actually on our phone numbers, and all of our contact information are in there as well. So I want to thank all of you for coming. I hope you found this useful and informative.